sorry, my connection, everything seemed to be taking ages to happen. So it seems like there's connectivity things all around. Yeah, so will we move the next session straight up then?
Yes.
Okay, that's super. So
we're missing one person from that next session. We've asked Thandeka to come and join us immediately, but I think that I'd be happy to get going. And I know Victoria's here as well.
Victoria, you're here. Emmanuel, you're here.
Emmanuel's not here.
Yes, I'm here. Yes, I'm here. Sorry, I was on mute. Yes, I'm here.
Yeah, I saw this really great meme about how the pandemic it's a bit like being in a seance. It was like, we can't hear you. Is there somebody there? Is there somebody there? So it does feel a lot like that in our current engagements. Okay, so Victoria, you're here, and then Thandeka is joining, and Emmanuel is not yet here.
Yeah, but we're just gonna have to go on. I think Emmanuel had said that he's been having connection issues as well. So
okay, that's great. So we'll go with that. So first of all, a very warm welcome back to everybody. I hope you had a restful and enjoyable break for lunch and managed to stretch and nurture your bodies and souls, and so your minds are ready for this afternoon session. I'm very delighted to be, well, it may be a very small roundtable, it may just be a small conversation at this point, to be talking about specifically creating medical humanities spaces in Africa, across the continent, connectivity and positivity. And in an ideal world, when all the connection issues are resolved, we will have 3 panelists on this. It will be Dr. Victoria Osei-Bonsu from the University of Ghana, Dr. Thandeka Dlamini from Eswatini, and Professor Emmanuel Obonwale from the University of Ibadan. While we are waiting for the others to join us, I would at least like to just send a very warm welcome and do a very warm introduction for Dr. Victoria Osei-Bonsu, who is also one of our regional members and one of the founding members of SEAM, as are the other 2 panelists in the session. So Victoria is a lecturer of literature in the Department of English at the University of Ghana. She completed a PhD in Anglophone Literary and Cultural Studies at the University of Basel in Switzerland in 2018. And her research interests lie mainly in post-colonial literary studies. She is currently developing and working on a self-directed research project on the interface between literature and health, with a focus on Ghanaian literature. Her forthcoming articles arising from this research examines the correlations between narratives emanating from the COVID-19 situation in Ghana and the communication of a health condition in Ama Ata Adu's story, The Message. So Victoria, I would love for you to share your insights, your thoughts with us today.
Thank you. Thank you very much, everybody. Good afternoon, actually, to you. In Ghana, it's still morning, so good morning also to anybody who shares my timeline. And thank you very much for this opportunity. Like the introduction shows, I'm coming into the medical humanities on an interest, actually. I have worked so much in post-colonial literature, and you know, looking at narratives of representation and othering and stuff like that for quite a number of years now, about a decade or more. And whilst I was finishing my PhD, I started to discover all of these, you know, representations in literature. It started with representations about the broken body or the ruptured body, and also representations about, you know, disability and stuff like that. And it caught my interest, and then I started to do a bit more research in how these kinds of representations in literature are discussed, you know, for the most part. And that's how I, you know, found my way into the medical humanities. So it's really, for me, a very new field of study. It's like starting a whole new research all over again. And then I was, like I said before, I was really towards the end of my PhD. So I thought to myself, let's get this one done, and then we can start something else, and then start to, you know, chart new paths, as it were. So yes, I got that one done. And so here I am, and charting new paths. I'm really excited about the new research that I am, launching into the new discoveries that I keep making. I also find that it's a lot of reading for me, because I really have to get into, the conversations that have happened up to this point. Of course, it's developed in very many ways, and in diverse geographical spaces as well, in different ways. What I have indeed discovered also is that there hasn't been very much in the African continent, but also primarily in West Africa, at least in my part of the African continent. I have discovered recently that there's quite a lot that has gone on in South Africa, in East Africa, probably in other parts of Africa, but I have discovered that there is very little in my section of Africa, West Africa. I recently came across a Francophone group, if you wish, of the medical humanities that appears to be based in Côte d'Ivoire, and I discovered that they were doing their own kinds of stuff, but from the perspective of Francophone literature and Francophone research. And so I reached out to them. It appears that I may be the only Anglophone person in the group. If I do get accepted in there eventually, I'm looking forward to that. But on this side of my geographical space, I happen to be the only person talking Anglophone literature and the medical humanities. That doesn't mean that there isn't research in things that would be related to the medical humanities. It's just that they do not think of it in terms of the medical humanities. So I have discovered that there are people who are doing research in language use and discourses and linguistics and medicine or health discourse. There are, of course, a lot of public health researchers as well. There are a lot of social science researchers as well. And there's also quite a lot of scholarship in the areas, in the interfaces between the health sciences and anthropology and like I said before, the social sciences and sociology and other things like that. But there doesn't appear to be anything at all in literature and health. And so this is, for me, in some ways also a rather, for lack of a better word, lonely journey, because I appear to be, charting this new course and sort of all by myself. With those that I get to talk to who may be in language or linguistics, that is really close to me, because in the English department where I work, we have two sections. So we have the literature section and then we have the language section. And so when I do talk to other scholars in the language section, they say, oh, let's see, you get something started and then we'll be happy to jump on board. But the whole idea is that I need to get something started first. So it doesn't appear that very many people are terribly interested in, going on this new journey with me, especially also where there is no funding attached to it. So it's really me just launching out my and, doing what I have to do with what I have available. So in many ways, baby steps, but baby steps with a few successes here and there, and they get me excited. I have been able to, with courses that I taught in the past 2 academic years, there was one that I taught before the COVID era, before the pandemic, teaching, modules. And then within the pandemic as well, I had to lead one that was done online. I had to lead a course online. And with each of these courses, so the one was Shakespeare and His Age, and I was able to thematize it around health and, looking at the metaphors of health and disease and illness and well-being and all of those that come through Shakespeare's writing. And it was really amazing for that kind of discussion to come out, because then people, the students started to talk about how they could actually then identify with this Shakespearean text, which was otherwise so far removed from them in time and in place as well. And the class discussions, were really invigorating and came up with a lot of, useful insights. It was really exciting. I now led that same course for the next academic year. I taught that same course in the next academic year, but during the pandemic season. And it was even more relevant because then the students were better able to identify with the discussion, with the metaphors of well-being and disease and ill health and all of that we were discussing within the course. And they could, it was even more familiar for them. They could even better identify with these metaphors of health, because they could actually see it in the pandemic. They could actually see how it it mattered to them, how it impacted on life, on social gatherings, on even their academics. And so it was really exciting teaching Shakespeare and His Age for me, thematized under the metaphors of health in the time of the pandemic.
Yes, we do now have this new timeline of everything being PC before COVID or after COVID, by the as we organize our lives. Victoria, I just like to thank you very much for that insight, and I'm going to also ask Chisomo to join us in this conversation, so we can bring another round around diaspora literature. But I wanted to go back to a few points you raised, Victoria, around that sense of isolation with starting a new field, and that I think is something that has featured in various ways in the conversations that we've had over the years, but also that the broader group has had over the years. And partly why we chose those ideas of edgelands, and it does always feel like when you're in a field that has as its roots a kind of intertrans or multidisciplinary component, and yet you have both the love for your own discipline, but you want to shift the boundaries or perhaps move outside and actively work towards building across the silos. There is, in many cases, a kind of wait and see attitude. So people will, they want to just see what it's going to look like. So that's an interesting thing of itself, that the impetus for why we move into fields or how we reshape our teaching or research or writing can be multitudinal. It can be because of the things that we are interested in as researchers, as academics, and what we want to teach and how our teaching or research interests lie. But you raise an interesting point as well around the implications of funding, that for a lot of universities, so much of the way in which developments in either research topics or fields happen is around what grant money is available, rather than around any kind of intellectual curiosity or a kind of other impetus for pursuing certain health things. And it becomes an increasingly important discussion in light of ongoing reductions of subsidies to universities from governments, the slow eroding of their notion of the public good of a university as more and more they're corporatized or, slowly managerialized. So I think that, those points are significant in terms of thinking about the field going forward and about what strategies we adopt around that. So whether we look, sorry, the thing is, mine keeps bleeping, everybody's arriving, I'm sorry, it's very annoying, that there is that tension of, trying to encourage new scholars or emerging scholars or ourselves as scholars into new fields, into these spaces, at the same time as, there feels like there's these incredible pressures on the humanities and the social sciences. So I think those are all key points. Shizoma, I just wondered if you wanted to jump in at this point and add any comments in terms of your kind of engagements with the diaspora literature and how you feel like, do you think it's different if the literature is kind of being written on from or about a kind of different context? Do you think there's overlap? Do you think there's more support in certain, do you think there's geographic difference in terms of how literature overall is engaged with or understood, and what that means for its engagements in medical and health humanities?
Yeah, first I just wanted to start by validating everything Victoria said. I started in the exact same position in 2009 as being not only the only African person or person of color in my cohort in 2009 at King's College London, doing Anglophone literature and HIV and AIDS, but finding myself completely isolated because what was wanted at the time was kind of like the African face of Western medical humanities, and I was not able to deliver. And it was a good that I wasn't able to deliver, because I think it's a wrong approach to start with from the beginning. And so my trajectory has been working against that completely. I found the exact same pressures that Victoria is facing in terms of being isolated and people focusing on specific issues of, oh, we don't discuss this in an African context. We do it in the linguistics, or we do it in this discipline. And then finding yourselves having to fight against that. And that actually became a core part of my own development of my own research grants. Part of the reason I started the Malawi Medical Humanities Network is because I said, if I do not prove that this thing is already happening elsewhere, I'm going to sink in isolation. So I think while other scholars had the luxury of just getting in there with their work, I was completely isolated in the fact that the work I was producing about Africa didn't reflect medical humanities that was being produced in Europe, even from Europeans writing about Africa. So I was completely on the verge of, I say, it was either sink or swim. And I decided that I was actually going to stop writing because I was tired of the rejections. And I was going to focus on building a network and working with people across the continent to prove that the work we're doing is legitimate in our spaces. And I did this at a great detriment to myself, because I've got scant publications for a reason. And I actually have more editorial work on my resume than I actually have my own writing, precisely because we're constantly trying to prove and validate the knowledge that's being produced by us as knowledge. So for me, that's what I found, is that has been the problem in trying to create medical humanities in Africa, is they want a mirror image of what's happening in the North. And I have resisted this, adamantly resisted this, and only worked in spaces where people will allow us to actually organically produce medical humanities as it is being produced. And medical humanities is not the same everywhere. I mean, the culture of literature in northern Malawi is very different than central Malawi, and very different from urban Malawi and rural Malawi. And that's the issue where I've always struggled, is to say that we're not trying to replicate a mirror image, but we're just trying to give space for different types of scholarship. So it's actually now in the last year of my grant that I think I've proved what I've needed to be proven. And I've actually put aside all the projects and saying, now I can work. And the reason I'm saying this is because publications are incredibly important in the process of validating medical humanities research, right? And I remember being very open with you that my first book that I published on my PhD was rejected, and they told me to remove everything about indigenous theory because it's not valid knowledge. 5 years later, I got an email from the same editor saying, oh, what happened to that book? And the change was Black Lives Matter had really opened up people to speak and push against racism in academia. We had Black in the Ivory, where we were spilling our guts about the epistemic violence that we were facing in the production of our knowledge. Then people started listening. So I almost feel like I'm very lucky to have survived that wave that would have crushed me if we didn't have this global revival of these discourses of the way intellectual and epistemic violence against, African knowledge producers has affected us in the academy. Now, it's not like Africa's, academia is operating in isolation. I mean, it exists, but as Victoria said, we don't have the funding or capital to push back. We're dependent on Global North funders to get it. And that we have to spend as much time as forcing these discourses and these spaces for people to get it as we do producing the knowledge. So when people say we have to work twice as hard, this is how it manifests. So as we're producing medical humanities in our respective spaces, we have to acknowledge that in order to do it, we are completely dependent on Northern money. And in order to do that, we have to work twice as hard to prove how this is medical humanities, despite the fact that it looks different. So that's how I wanted to kind of, I know I just rambled and ranted, but I need
I think these are very key, and these are very key discussions, and they've been at the epicenter of a lot of the discussions that we've had both formally and informally throughout the, talking about what it is that medical health humanities should look like. And as you may remember, one of the first discussions that when the kind of South Africa cohort was trying to build up was whether the terminology even made sense.
Yeah.
Because medical humanities is as it's been constructed in other spaces, does have a kind of, there's a certain sort of series of histories that go with it, a certain sort of bifurcate, like splitting in the paths and sort of 4 or 5 spaces in which it belonged. And, the discussion of how do you engage with the field, understanding, what can be learned from how a field has been created in one context, but create a space where it forms and grows organically in a way that isn't a reproduction. It isn't a some sort of tatty reproduction of a field in another space. And but also the very practical realities that, if you want to call, so we ended up with medical health humanities, or we took up critical health humanities. But when you want to start looking for funding, which is needed, we need postdoc money, we need money to run things. There is this tension between applying within the boundaries of a certain type of genre of expectation, and how there's that tension between that and what you might want to happen, and this growing. Yes, and it is. I mean, there are these interesting moments that have happened. There's, suddenly there's also, as we've experienced well, when there's suddenly an interest in something that's coming from either a new cohort of academics or an area where it hasn't been before, that suddenly there's all sorts of invitations to conferences and things that really are not about reciprocal, kind of conversations, but more about having native informants, for lack of we'll shout out the people from Africa or from whichever area of the world is currently fashionable, to represent how far ahead we are in the field, or how and it's a reproduction in many ways of some of the discussions we've also had about the power dynamics of research and publication. That you'll often see people will suddenly align with writers that they don't know from Borisov because it's politically expedient for certain careers, and the question then becomes, well, whose careers get built and whose get hampered or in other ways altered by, as you mentioned, some of these multiple layers of work that need to be done, both a kind of a necessity to validate when that's just tiresome and exhausting, but also a capacity to get to a point where you can say, look, we don't need to prove this to anybody anymore. Here it is, here are the things we've done. And that's a very deep tension and speaks to the ongoing disparities. And you face, as you mentioned, there's also the inequalities within institutions in any one country as well. So there's also the tensions of the internal politics and dynamics of universities on the continent and between universities in one region, let alone many regions in the country, and how that shapes our thinking and what we do. I see in the comments that Oyotondo said that the next step needs to be to create a West African medical humanities network. Absolutely. Victoria's kind of part of SEAM because we don't have a WEAM yet. It would be another acronym. But that really would be the ideal space. It would be amazing to have like 4 or 5 regional networks that could work together. And as you say, Victoria, we could how do we do the stuff so that we don't feel more alone or more isolated? My experience of isolation had to do with being in a health sciences faculty, and I mean literally having conversations where people would say things like, you know, I don't care if my students are racist as long as they do the surgery they need to do. Like, as long as they can sew people up, like, it, you know, what you're teaching the stuff about race, class, and like, it's not relevant to healthcare practitioners. Like, what they need to do is they need to be able to do their jobs. And of course, on one hand, there's truth to that. Like, you know, you need to be able to sew up something. If somebody's bits are out, you want to put them back in where they should be. But the lack, like, the two things that struck me about that was, first of all, the assumption that somehow the person providing healthcare or the person receiving it is a disembodied thing, either a particular injury, a particular scar, a particular wound that needs addressing, or the person applying that dressing, as if there is no connection between the physical and the embodied self. So that was a kind of quite, I think I had assumed it was there. It was the kind of sheer, and this is quite a senior, like, high-end professor. I mean, this is somebody with a lot of status in the faculty, and the sheer kind of presumption to speak on something that they knew nothing of, quite blatantly. And I always have this kind of secret fantasy of, like, walking into an operating theater and go, well, I'll do the heart surgery today. I, like, roughly know where the heart is. Like, it's kind of, I can do that, because it often feels like there's that thing that there is that lack of epistemic generosity, but also epistemic respect for work, for knowledge, for how it's produced, both in terms of where and how it's produced, but also in terms of the disciplines that people have trained in. So I think these are key points. Victoria, I mean, other reflections or thoughts from you? I'm just trying to check out time. No, we're still good. Okay.
No, we're still good. I think we the two other guests have not showed up, and I have not heard back from them. So I think that we have the capacity to just keep going until we get some form of response. So we've got about 27 minutes.
Oh, excellent. Well, then perhaps also, yeah,
I'll just respond after Victoria, and then Thandeka has joined, so we can have
this.
Excellent. Yeah.
Super.
Yes, so like I mentioned, ended probably on the baby steps and the little successes. And in some of the teaching, I have been able to get the interest of students. And so I am really looking at, you know, bringing up these younger scholars, potential, you know, researchers into the field. I did manage to get one student who was more than happy to do a paper, a project on, you know, in what I would consider.
Sorry, Victoria, can I just ask those who aren't speaking to please turn off their microphones, because we're starting to get an echo. Thank you, Victoria.
Thank you very much. Thank you. And it turns out that she comes from a background where she has a child who needs care, who needs constant care. And so as a mother of a child with cerebral palsy, she is in many ways, you know, an activist in by herself. She actually trained as a journalist and is thinking of other ways to bring her activism for, you know, healthcare and support and stuff like that. So I am also thinking about ways in which from my place of you know, being in academia, we could also reach out, you know, to these other kinds of professionals, or this person in the media or in journalism, raise some form of awareness for the kinds of things that we do, the kinds of research that we conduct. And this was some of the thoughts that also went to this paper that I have just recently completed and submitted to a journal for publication, which looked at the interfaces between the COVID-19 pandemic and this text, this short story by Amata Edu. It was interesting for me in the sense in which I discovered that health communication often gets diluted in you know, layers of confusion. And so if the person either does not speak the language of the health communicator, they could, you know, get completely misled as to exactly what they're being told about their condition, or even about what interventions they may, follow to get better. And we've discovered quite a lot of this during the COVID-19 pandemic, where Ghanaians took to social media, especially Facebook, but also other forms of social media, and expressed their views about, what the government was doing, the measures that the government was taking to combat these kinds of things, and how some of the communication wasn't very clear to them at all, because it was all, captured in a lot of medicalese and political language and stuff that didn't quite apply to their everyday lives. And so there is a very popular caption that emerged from all of these conversations in the local parlance. It goes by, of course, it's a combination of English and the local parlance, by June, dear, which basically means, at this rate by June, and then people would just add on. And so it goes, at this rate by June, and then they leave the ellipsis. And then people just add on, we'll all be dead. And even though we were long past June by the time most of these conversations kept coming up, it stayed. It became, a caption that just stayed with people. And till date, people would still use it and say, at this rate, by June, people would not be vaccinated, or by June, and then they express their thoughts. And I thought that this would be some place that one could start from to pick up narratives about health that, apply to the everyday life, that people, even the people in the streets or just ordinary people can understand without having to sift through, the kinds of communication that the government or the medical personnel, would bring out, which comes out with with very technical language that they don't always.
Absolutely. And I think,
Thank you.
The discussions around, the significance of how public health messaging happens, and the myriad of examples of both poor and good messaging, and similarly, the discussions happen in environmental humanities circumstances as well, that often there is an inability to translate between certain types of knowledge into more accessible. Before I bring Thandeka in, Angelo had raised his hand and has put some commentary in the chat, and of course, as somebody who also sort of in one of his academic incarnations was involved in English departments, I'd just like to bring him in for comment here, and then after that I will introduce Thandeka more formally. And Thandeka, you can then speak a little of your experiences of developing medical health humanities in the context for you, and how your journey has been. So Angelo.
Yeah, so thank you, Dr. Osei-Bonsu. I find what you say echoes very much, in some senses, the isolation that one had in a department and a discipline that often sells itself as very broad and very inclusive and very open-ended, that includes things like, oh, you want to look at, representations of health. Of course, in the English department, you should be able to do it. But ironically, that very same kind of discipline is also very myopic and very specific, and tends to be, particularly in the British post-colonial world, quite oddly articulated with the global north, often either trying to catch up or trying to outpace by being a vanguard for the cutting edge of nothing. But what happened in South Africa in the 1980s and 1990s was that people, and these were very isolated people, they were literally individuals in some cases, who wanted to pursue within their research, within their studies, aspects that weren't articulated, accommodated within the mainstream curricula, journals. They would often, establish a journal. And in the 80s, they used to be roneoed off, and pretexts began like this. It was an attempt to bring Marxist cultural studies into an English department that was deeply formalist and deeply kind of great tradition, pre-cultural studies. And 2 people in a staff complement of 35 people started a journal And over 5 years, it was this kind of sidelong hobby, but it became a mainstream accredited journal with the field attached to it. And the same happened with the African Gender Institute, where it was Amina Mama pushing for a journal that became Feminist Africa, along with Desiree Lewis, Elaine Sallow, and others, working in very isolated from the mainstream space. And your isolation in West Africa that you described just reminded me so much of what people in the 90s had discussed around me, and how we, Pumla Gola, myself, Habeba Badurun, felt we weren't getting published in journals, so we started our own, and it became a field. And so that might be a way to find new colleagues, in addition to the ways you've outlined already, by finding students, and alert people who may be working in isolation to the fact that there is something and that you could become a critical mass. So yeah, just a note of support and a lesson from somewhere else that might be useful, but actually also might not be.
Thank you very much, Angela. And I think, I mean, this has been one of the discussions that have come up, is do we start creating or thinking about creating medical health humanities journals that are in and of the continent? And we've had discussions with Kadesha, we've had discussions, in here and there. Do we also make use of existing journals? Because in some ways, the labor required to get journals accredited now and to get it becomes a whole, a huge discussion. But there certainly is no, Angela, as you say, like there's nothing to stop us working out how to find the critical mass, to make the connections and provide space for that. I'd like to give Thandeka some time to talk. So Dr. Thandeka Dlamini is a medical anthropologist with a PhD in critical global health. And she likes to interrogate the global-local nexus of traveling global health policies and strategies and how it plays out in local settings. And this has been a particular focus of her doctoral thesis. She's a specialized qualitative researcher, and she enjoys investigating a number of things, including decision-making structures, dynamics that influence individual choices, and priority ranking that shape behavior patterns within social classes, race, and how these ideas evolve over time. And she is our country rep for Eswatini, and currently focusing on networking and writing, and asked some key questions, I think, for younger and emerging researchers of Peter earlier. So Thandeka, do you want to tell us a little about your journey and about the things for you that you think would facilitate connectivity, positivity in creating medical health humanities spaces across the continent or in specific areas?
Thank you, Carla. I just put on my video. I don't know if you can see it. Our connection here is not the optimal, but we'll make do with what's available. So I'm really, really happy to be in this space. It's really exciting for me because I really feel this is where I belong. For a long time, I think I've been misplaced. I've been stifled and all of that. So I really am happy to be part of this network and this conference. I'm going to speak about mostly my experience. I mean, I'm an early career researcher, so I have a lot of questions, as you have noted, but I want to speak from my experience. Mostly my experience is drawn from development, where I was working for 15 years before I did my PhD, and that's why I had an encounter with medical health and humanities, and deeply embedding myself into social science methodologies. So I was trained as a social scientist, but when I got into doing my PhD in medical anthropology, and I realized that what is called social science and what I was trained on is really, really, really lacking. So I mean, I wanted to delve more into what I've observed as part of that journey of my life in my career, and then also talk about public health, because that's the space where I was able to then delve in deeper in terms of understanding medical health humanities. So what I want to talk about first of all is that I worked in different types of development sectors, and one of the things that stood out for me a lot was really the standards of research within the country where I was working in, which is mostly in Eswatini. And I was just surprised how the different methodologies of research and what represents people, feelings, people's perceptions and views was being presented in upstream platforms. The idea of premeditated choices and people really like sort of told what they should do so that those kind of things come up and inform the programs that they were doing, and which was supposed to be a shade of what the experiences of the people were at this during those times. And then also I had an opportunity to teach in some learning institutions. I was really surprised in the level of quality in terms of content, how outdated the content is, the quality of output that the students were coming out with in terms of narratives and explaining phenomena. Because, you know, what I could get when I was engaging with people directly and what I would read in the reports or in the conferences or in the conference rooms was being represented. For me, there was a disconnect. And also, you know, I realized that there was a lot of politics in the knowledge production, and this is something I was always, you know, even in my doctoral thesis, I was bringing this up a lot. But, you know, these were some of the things where we were told that, you know, you cannot really be critiquing this aspect, you know, your donor being this and that, and this is going to upset people within, you know, powers that be. So we need to delete this kind of assertion within your paper. And even if you want to do, and I wanted to do certain publications, I was told this is too critical. You are not yet at the stage whereby you have authority to talk about these things. You just have a tiny weeny antidote somewhere, so you can't really write about these kind of things. So yeah, those are some of the things that I have also noted. One other thing that stood out for me when I was doing my doctoral thesis especially was the weak institutional system within public health itself. It looked as if our health officials that are supposed to lead the health programs, they were really, the whole health system, it looks like it has been crippled, if that's what I could say, or they've become despondent and they don't have agency. They are just having cosmetic leadership, because you'd find there are these global health policies and strategies that trickle, you know, from the global to the local, and these are supposed to be taken up. And then I remember engaging one of the very senior officials within our government, Minister of Health, and asking them about, you know, why does it seem that everything that's being said, we have to follow it. I was mainly using the HIV treatment guidelines that time, because that's what my doctoral thesis was around. Like, for instance, if it's now 350 CD4 count to initiate, we do that the next day. If it's 500, we just move in motion like that, like no total consideration in terms of, is this realistic for the system to do? Do the patients want this? Is this feasible, and all of that? I was surprised by the response that she gave me. She was like, you know what, we are helpless in this situation. We just need to do what we're being told. After all, these people are giving us money. So you can see that, you know, lack of discretion there. You can see that no agency, and it looks like priorities are externally determined, and as they are detected, that, and that has to happen. And it was problematic for me, because it seems that, you know, this is like colonialism that is, you know, continuing in a new form within our times. And I was like, this cannot be acceptable. There's got to be something that needs to be done to be able to change the tide and make sure that whatever gets done in terms of implementation of interventions within the country needs to have some consideration of sort in terms of the system, in terms of the patient experiences of the health workers themselves, and otherwise not just a copy and paste model. So then another thing that I have realized is that there's the institutional system being so weak for undertaking research within our countries. Then what happens is that this weakness or void becomes supplanted with, you know, international NGOs coming in, that comes from academic institution in the US, for instance, where they come up to set up home within the country, and they actually do the research. that needs to be done, with total disregard of what systems are in place, what universities are in place, or academia, instead of working in collaboration with, at least so that there's skills transfer, there's strengthening of the system, or there's also, you know, impartation of skills for people that are local. Nothing of that sort happened. It's just a completely parallel system. We come here, we have issues about HIV, we have issues about health, NCD, or what have you. So because there's no capacity here, then what we are going to do is just bring our own expertise, we do what we want. And I find gross misrepresentation and, you know, ethical issues that happen there. For instance, you know, when we're having the treatment scale up of HIV in the country and the issue of testing people, you know, the guidance was that people have to, you know, opt out or in out of testing. But when I was doing clinic ethnography in the different facilities, I realized that there was none such a thing like opt out. If you come through that hospital door and you need some services from the government, you have to be tested. You like it or you don't like it. I mean, it was put as something that's mandatory, and yet in paper, the protocol was people could opt out. And when I engaged with the patients, they were like, no one told me that I could choose, you know, I need to be tested so that I can be able to have further on service for what I have come here to do. So I found that there's a lot of these prejudices that are happening, and a lot of this, you know, sort of replacing of the actual system within the healthcare setting, such that whoever wants to have answers about this particular issue in the country, they'll just establish their own because they have the financial power. And if this happens, the problem becomes that these people get control and power over the knowledge that gets to be produced. For instance, in the project I was working in, you know, I was engaged in as a social science researcher to actually make sure that the emic perspectives of the patients are being heard, so that it can influence the program, because it was a pilot project. But what I realized was that all those success factors were arithmetic. There was nothing about embodied experience of the patients, of the healthcare workers. So everything was just about equipment, was just about us being able to do this and that. And then this was really problematic, because at the end of the day, there is reports that are saying, oh, this project was very successful because, you know, it's based on targeted people so much, and then we were able to reach 80%. Everything is metrical. Everything is metrical. Nothing about experiences, which is really what we should fight for as medical health humanities scholars, so that we make sure that it's not only just the, you know, the tangible, but also the intangible sources of success that we can bring on board to influence whether projects are successful or not. So I think for me, that's my experience. That's where I have been in. I think, but on a personal note, talking about creating more spaces for medical health and humanities in Africa, I really believe that it starts at a personal level, because I really like what Shay said yesterday about being militant and calling out. I also call it being radical, because if you believe that injustices and prejudices in terms of how global health is being administered, we have this prerogative at an individual level, like within our networks, our, you know, the work that we do and what we choose to be involved with in terms of the kind of projects that we do, how those projects gets to be done, in the work that we're doing, how can we influence and change the stereotypes that are there in terms of approaching service delivery within public health, approaching, you know, telling our children about these prejudices, and wherever we have authority or space to influence people, we do that. I had a privilege, which I'm very excited about, to be invited to write a book chapter within medical humanities, and I was so happy because I took that to be the opportunity to write the paper that was rejected, and I was told I cannot submit it anyway. So I was happy, because one of the things I noted within the healthcare system was that, you know, when the HIV treatment came into board, there was this precondition that people living with HIV/AIDS, they are supposed to use their body to model the efficacy of drugs. And I really found that that was the lowest bridge of the dignity of people, to be able to use them for others to see that drugs are working, and therefore this is how they will be able to come and work in the facility. And for these people, they are not looking at that kind of issue and dehumanization, but they are looking at a livelihood, because they will have a job to support their livelihood. So I was able to frame that piece and make it a chapter within the book. And I'm hopeful that, you know, it will come to a point of fruition, because I think we also need to talk about these prejudices and the experiences that we find along our course and trajectory of our career. So that's one thing that I've done at a personal level. And being the representative for medical health humanities in Eswatini, one of the things I've noted is that, like I spoke about, the standards of research and the quality that comes out of it. I think we really have an opportunity, and I've started engaging some of the colleagues within our universities and see how we can really infiltrate the space, especially for departments that call themselves social science, and look at what's being done and where the gaps are, and see if we can start even with just having seminars, so that we can already have this conversation simmering and have an opportunity to break into these kind of mainstream platforms and try to change those stereotypes that are there. I think that's what I can say for now. And yeah, I think there's more that could be done, could be said, but that's all I want to say for now. Thank you.
Thank you, Thandeka. Thank you for speaking those things. And I think what has been an ongoing theme over the last, Selma, I see your hand, has been an ongoing theme over the last few days, has been around the ideas of where power and hierarchy is reinforced or reinscribed, and what mechanisms are in place to try and address that. So, you know, we need people to fight, we need people to build, we need people to think, we need people to do that. There's space in creating a new network for people to bring their energies and their concerns and interests in specific ways. It strikes me also, I mean, this conversation about, you know, the parachuting researchers, which is also often also leveled at academics who do research on communities, and then, you know, so they parachute in, they make their academic careers, and then, well, they parachute in, get the data, disappear, make the academic careers. And it similarly has come up in discussions around particularly recent scholarship in queer theory and feminist sectors around trans bodies. There was a very powerful email written by a trans activist, you know, saying that they had seen, you know, X number of their friends commit suicide because of the difficulties of their lives. And yet, you know, in that same time, X number of academics had made their careers off writing the story of other people's trans bodies. And, you know, there are similarities in the narratives in terms of race, in terms of class, in terms of gender, in terms of sexual orientation and abilities. And so it's also, you know, I think something to hold in mind, that we can learn from all the spaces where these variations and flagrancies in power and privilege dynamics have played out, and work out how to go from there. I see we have 2 minutes, am I correct, before the workshop needs to start. So I would like to, Shasoma, you had your hand up, and to ask if there were any other questions from the audience. So we can take Shasoma's question, I'll take one more, and then everybody has 30 seconds to wrap up with their final thoughts on connectivity and positivity. Okay, Shasoma.
I really wanted to talk about parachutes. You've brought up exactly what I was hearing from what Thandeka was saying, is that we have to really avoid this as we work towards building medical humanities in Africa. I think, you know, part of the problem is that the partnership grants makes a lot of funders easier to know that there'll be some sort of global north component. I want to focus more on collaboration. I find it to be such a joyful experience to collaborate and not continue, even with what I see as a person like myself in the diaspora, that we're kind of sent to be this kind of global north adjacent. It doesn't have to center, you know, the needs of global north. I really do think it needs to be about empowering, uplifting, and funding independent African spaces so that this work can get done. And I think that I also just want to say very quickly that also it's going to look different. Transdisciplinary research, interdisciplinary research is a more dominant and focus of how we're looking at this in Africa. And it's not necessarily the case in the global north. And what I find is a lot of these institutions will start poo-pooing that aspect and saying it's not rigorous enough. And I think that there are spaces for us to be radical and push back against this and allow African researchers to define what medical humanities looks like in their own space and fight for that.
Thank you so much. Okay, we are rapidly running out of time. I would like to give any of the earlier speakers so Victoria, perhaps Thandeka, I don't know if you want another 30 seconds, if you feel like you've said what you need to, and Angelo, possibly just any final thoughts that you have on this. So Thandeka, do you need to go, or are you okay?
I think I'm okay, thank you.
Super. Angelo, you're okay? Okay, Victoria? You're good.
Okay, I'm all good.
Ever.
Yeah, I'm all good. I just like the little comment on what Nolwazi has just put up about the concept of joy in healthcare, helping us to think differently about the different things that we do. And yeah, for me, I really think that so far the journey has been joyful for me in many ways, in the different discoveries that I've made about how it works out differently for me from the kinds of conversations and articles that I've read from the global north, and how I often think, well, for us, this is a little different, it works a little differently, and it's not quite the same. And I really liked the morning session in which there were all of these performances and how the discussion went on about how these performances, contribute to the healing process. And during that session, I would have asked, but I thought, well, maybe just let it go. I was wondering about the continuity of these kinds of processes, of these kinds of cultural and traditional modes of expression that, contribute to, social well-being as well as mental well-being, and how, especially in these these pandemic times, as it were, we get muffled sometimes because we have to wear the mask and we have to be socially distanced. And I was wondering a lot about the the future and the now of such expressions, cultural expressions of health, and how these would contribute to well-being. And that's just something else that I'd like.
Excellent. I would like to thank all the participants. Thank you for your insights, your input, for sharing your experiences, your stories, and they certainly help all of us who are here and all of us who are trying to build medical health humanities together to think through what our requirements might be, from practical to philosophical to political. So thank you very much to everyone, and I'm now going to hand